Good afternoon, and thank you for joining us. Today's HealthyU webinar is brought to you by the Back and Neck Pain Center at Mather Hospital, and the topic is There's a Better Way. At any time during the presentation, please feel free to enter any questions you may have using the Q&A feature at the bottom of your screen. We will answer as many questions as we can within the time allotted once the presentation concludes. Your questions will remain anonymous. Today's presenters are Dr. Ben Eliyahu, Caitlin Conville, Melissa Hefner, Dr. Samuel Brown, Kristen Klein, and Dr. Daniel Burke. Dr. Ben Eliyahu is the Administrative Director of the Back and Neck Pain Center at Mather Hospital and Director of the Mather Chiropractic Collaboration Program. He has advanced certification in sports injuries and pain management. Dr. Ben Eliyahu has been in private practice in Selden, New York for 34 years, where he directs an integrated and collaborative spine and musculoskeletal practice. Dr. Ben?
Good afternoon, everyone, and thank you for attending our webinar today. Our webinar is on back and neck pain, and the title is There's a Better Way. And the reason that it's a better way is if you just take a look at the mix of speakers that are presenting today, you can see it's a very multidisciplinary teamed approach, and that's what makes our program a better way. And we'll get into that after we talk about other reasons for why back pain and neck pain occur, and then the different options that are available. Am I still on? I lost the screen.
You're still on.
How do I refresh my screen? I don't see it.
Maybe if you hop out and hop back in.
Ooh. Sorry about that, everybody. Okay, so let's get started. Next slide, please. So just a little bit of an introduction. We're going to talk about the reasons for why back and neck pain occur. We're going to talk about our particular uniqueness of our center at Mather Hospital, what we do, the types of team specialists that we utilize to help our patients achieve health, what our guiding principles are, and then the importance of other things that we call risk factors that help to modify and prevent recurrence of back pain and also help rehabilitate back and neck issues. Next. So why isn't your back and neck pain going away? Well, there's lots of different reasons. We're going to talk about some of them, and forgive me if this is a review, but the reasons anatomically for back pain vary. There's mechanical reasons, and when we talk about mechanical, we're talking about the joints of the spine. When there's muscle reasons, we can talk about muscle spasms and trigger points or knots that occur in the muscles. And then in the middle picture, you can see there's actually a cross section where the arrow shows a bulging disc. There are disc problems. Discs can bulge, they can herniate, they can rupture, and they can cause all kinds of issues, pinching nerves. And then on the far left of that picture, if the nerve is pinched, it can actually cause something we call sciatica. And sciatica is the big nerve that goes down the leg out of the back and creates leg pain. And that typically is from a herniated disc where the nerve is being pinched, as you can see in that bulging disc picture. Then there are fractures, less common. Sciatica we just talked about. Arthritis can build up in the spine, and that's called spinal stenosis, which is a choking and narrowing of the canal. And if you look at the pictures, the MRI pictures on your far right, they're pretty well labeled. The bottom one shows the herniated disc. You can actually see the jelly bubbling out backwards, and that's a herniation. You contrast that to the arrow that says normal disc, and you can see there's a vast difference between the two. As that disc material bubbles out, it can cause pinching of the nerve, which can cause back pain and leg pain. And then on the bottom, you can see spinal stenosis. Spinal stenosis is a narrowing of the canal. The spinal cord gets choked, and it can create a whole host of different symptoms, which some are amenable to conservative care, which we'll talk about, and some require surgery. Next slide. So from a mechanical standpoint of view, if you look at the top left picture, the arrow is showing what we call facet joints. Facets refer to the spine joints in the lower back. They can become arthritic, they can become thinned, the disc can thin, And as the disc thins, it allows the joint space to get narrowed. And you can see in that middle picture where it's showing redness around the joint, that joint's actually degenerative. It's thinned and it's become inflamed. We call that facet arthropathy. And that can respond to medication. It can respond to chiropractic manipulation or physical therapy mobilization. But sometimes those don't work and they need interventional treatments like injections, which our pain management specialists will talk about today. And then on the far left bottom, you can see the picture that talks about sacroiliac joints. The sacroiliac joint is probably one of the most underdiagnosed reasons for low back pain. Extremely common in people who've already had back surgery. It puts a lot of extra stress on those joints. Women that become pregnant because of the increased weight gain, or people that are obese, have a lot of stress put on these joints, and a lot of times it's overlooked. And a good clinician who's really adept at doing examinations and differentiating different pain generators knows how to exclude or include the sacroiliac joint as a pain generator. And we at the Back Pain Center and all the specialists that you'll hear from today are extremely adept at making these differential diagnoses. Next slide. So the guiding principles of our center. So our Back Pain Center is patient-centered, meaning that we include you in all our decisions. We make timely appointments. So if you call and say, hey, I really need help, you're not going to hear, we'll see you in 6 weeks. You're going to hear, we're going to see you probably within a week, usually 4 to 6 days. We take a step-ladder approach to care, which means we always start with the most conservative, least invasive care first, because our data from the last 8 years show that 75 to 80% of the patients that we see, most of them get better with physical therapy or some sort of conservative treatment first. Probably I'd say about 18% need some sort of pain management procedure, which is minimally invasive, and only 2% require surgery. We take a population health focus, and what that means is that we look at everything. We look at the risk factors. We look at your medical comorbidities and things that you didn't even realize you had. We try to include in our treatment algorithm so that we're taking care of the things that perpetuate back pain. One of the most biggest things about back pain is it keeps coming back. And the reason why it keeps coming back is there's usually an underdiagnosed or an overlooked risk factor that's not been addressed, such as comorbidities like diabetes, smoking, being overweight, not eating right. Those are just some, to mention a few. And then the last guiding principle that we utilize is right provider at the right time. So if you come in to see us and you have a raging leg pain, it's numb, it's weak, we're not going to start with physical therapy. We're going to start right away with some sort of pain relief injection. Or if you have something called red flags, which we'll go over later, you might even start with a surgeon. Next slide. So here's our stepped approach to care. If you look at the bottom, we have physical therapy and chiropractic medicine on the bottom. And some people choose one or the other. Some people don't mind one or the other. But both of these are minimally invasive. They're not invasive, and they're least invasive and most conservative. And then if patients aren't responding, we move up that ladder. And along the way, you can see we have support programs. We include mind-body. The mind is an important part of pain. Chronic back pain can lead to depression and anxiety. The more depression and anxiety there is, the more pain can become amplified and become a big issue. So you kind of have to take care of both. And at the Back and Neck Pain Center at Mather, we always look at that as well. You'll hear later about the role of diet and nutrition in your back pain and any pain regarding inflammation. We always use advanced imaging to help diagnose your problem, and we always counsel you on exercise, and our physical therapists help with that as well. However, sometimes those don't work, and we have to go up the ladder to pain management. And you'll hear from our pain management physicians today. And then lastly, 2 to 5% of the time, surgery may become necessary. And then you'll hear from a spine surgeon today about when spine surgery is necessary. Next slide. So now I'm going to introduce you to Melissa Hefner. She's co-chairman of our outpatient physical therapy department, and she's going to talk about the role of physical therapy in taking care of back and neck problems. Melissa?
Hi, good afternoon, everyone. My name is Melissa Hefner. I'm one of the physical therapists and assistant director in the outpatient physical therapy area. Next slide, please. While many of you may have been to physical therapy in the past, but for those who haven't, physical therapy is a conservative approach. Oh, I'm sorry, I can't view thank you. To rehabilitate your neck and or back problem and to improve your quality of life. It helps prevent the onset and or to slow the progression of the conditions resulting from a disease or any other causes. I'm sorry, having a hard time viewing. All right, next slide, please. So some of the many benefits to physical therapy are pain management, reduced need of pain medicine and medications, avoiding surgery, improving a patient's mobility and movement, whether with or without surgery, facilitate the recovery from injury or trauma, improve strength, balance, and endurance to reduce the risk of falls, and to the management of age-related medical issues. So once a physical therapist has taken you through a thorough evaluation, a treatment plan is created based on the individual findings. Some of the treatment techniques that may be implemented are therapeutic exercises, so strengthening and stretching techniques to strengthen the core and postural muscles. As a patient progresses and they can tolerate a little more, then we can implement some aerobic or endurance activities where we may utilize treadmill, bike, ellipticals, new steps. Manual therapy techniques are an important part of treatment sessions, especially in the beginning of the stages of treatment. We may use soft tissue mobilization, myofascial release, and manual stretching techniques. Some modalities used in the clinic are ice, heat, electrical stim.
We can't hear you, Melissa.
Christine, you can't hear me?
Now I can hear you.
You didn't hear me the whole time?
We got up to electric stimulation.
Okay, so once we've helped reduce the pain and improve your range of motion and function, we can then focus on more functional activities such as returning to work, returning to the gym, or any other activities that you may have stopped or been avoiding because of your pain and weakness. As a patient starts nearing the end of treatment and preparing for discharge, then we like to change our focus to more home exercise program, patient education, postural education, and lifting techniques that patients can take with them even when they're done here. This gives us an opportunity to educate and empower a patient to become independent with their exercises and ensure them that they're using the proper body mechanics so they can continue their exercises once they've discharged. This helps patients implement an exercise program into their daily routine, which can help prevent reoccurrence from happening in the future. So as mentioned on the previous slide, strengthening of the core and postural muscles are an important part of physical therapy to help with neck and back pain. Core muscles are located deep within the trunk, extending all the way from your head to all the way into the pelvis. These muscles are there to help protect the spine. So strong core muscles can make it easier and safer to do most physical activity, where on the other hand, weak core muscles can often lead to neck and back pain, make you more susceptible to muscle injury and poor posture. Next slide, please. So one particular technique that we use in the clinic, which we have seen success in treating neck and back pain, is the Mckenzie Method. The Mckenzie Method is an effective evidence-based approach to helping with neck and back pain. Oops, sorry, the slide is all moved. Once directional preferences, a clinician or therapist will take you through a series of repeated movements to find what is called your directional preference. Once a directional preference is found, an exercise program is created to promote the movements that help reduce or localize your symptoms and avoid the motions that produce or increase your symptoms. This technique helps the body's potential to heal itself. Once the management technique, once you're nearing discharge, symptom management techniques are taught to prevent reoccurrence in the future. With that being said, thank you, and I'd like to turn it over to Dr. Ben, who's going to discuss chiropractic care. Thank you.
Thank you, Melissa. So you just heard about the role of physical therapy at our hospital. And for some of you who've never been to a chiropractor, I'm just going to give you a modern concept introduction to chiropractic medicine. I've been in practice for a long time, probably about 38 years now in Selden. and I've also been the administrative director of Mathers Back and Neck Pain Center. So I have a very diverse and interdisciplinary experience to share with you on the role of chiropractic care in treating back and neck pain. Next slide. So for those of you who've never been to a chiropractor, most chiropractors in today's day and age focus mostly just on the spine and musculoskeletal system. It's a drug-free, hands-on approach using very comprehensive patient examinations, make a diagnosis, use imaging such as x-rays and MRIs, and then recommend therapeutic and rehabilitative exercise along with chiropractic medicine. Chiropractic care has come a long way. Probably if you had asked a medical doctor or the AMA 25 years ago what their thoughts are on chiropractic medicine, they would have said, don't go to one. But since then, what's happened is there's been many random controlled clinical trials that have demonstrated that chiropractic medicine is quite effective for the treatment of back and neck pain. And insofar as saying that, the AMA has actually recommended that chiropractic medicine is now one of the first line approaches for treating back and neck pain, excuse me, as well as the FDA, the CDC, the Joint Commission, and the American College of Physicians. We have many chiropractors that have been vetted by the hospital that are on our website. Next slide, please. So these pictures just kind of show you the different things that chiropractors can do. The very top left picture is a manual hands-on manipulation. Some people refer to that as cracking of the back. Although that makes a pop noise, that's nothing really actually cracks or pops. As the joint is separated and mobilized, what happens is gas is actually released from the joint is what creates that noise. However, that particular technique is not good for everybody. There are certain people that should not have that technique. What just happened? Christine?
We still hear you.
Yeah, but I lost the pictures. It went to the survey. Does everybody have that?
Nope, we're still on your slide.
Well, that's bizarre. I'm not sure why that happened. Mine went right to the, the survey. All right, why don't we move on to the next section? I'm not sure. Caitlin, can you kind of take over? Because I'm not sure what the next section is. Caitlin?
I'm sorry, what was that?
My screen, I'm not sure what happened. I lost my screen. So
Okay.
if you could just take over and move on to the next section, which I think might be Kristen.
Yeah, it's me.
Introduce her.
Sure. So I'm just going to introduce Kristen Klein. She's a nurse practitioner who works in interventional pain management, and she's just going to talk to you today about some different injections that they do in pain management offices and a procedure called Intracept. Kristen?
Thank you, Caitlin. Thank you, everyone, for attending. I'm Kristen Klein. I'm one of the nurse practitioners over at the Pain Institute of Long Island, alongside Dr. Brian Durkin and Dr. Samuel Brown, who will be presenting later on after me. I also work per diem for the Mather Back and Neck Center, so you may see me if you come in for an appointment. We're going to talk today about some of the minimally invasive and injections that we can do to help your pain within your neck or back. There's been preconceived notions for years that pain management is basically pills or medications. And yes, we can do that for you, but that's not the goal. The goal is to get you to functioning, living your best life. And we can do tons of things to help your pain that don't involve medications. Typically after PT or chiropractor care may not be fully beneficial for you. Many times in the past, people have thought that there's either epidural steroid injections or surgery, and there's nothing in between. But the field of pain medicine really has been just exploding with all these minimally invasive options, and we're going to go into one of them today. Next slide, please. So some interventional treatment options. You have epidural steroid injections. We do facet joint injections and ablations. That's both for the back and neck. The Vertiflex, which Dr. Brown will be talking about after me, and the mild procedures for lumbar spinal stenosis. You have your sacroiliac joint injections, and those can also be ablated. There's also newer procedures where we actually are able to fuse the joint. That's minimally invasive. Spinal cord stimulation, and then I'll be talking about the Intracept procedure a little bit later on. So these are all things to help bridge the gap between your pain, physical therapy, chiropractor, and maybe preventing surgery as long as you don't have any red flag symptoms. Next slide, please. So what's an epidural steroid injection? It may be due to when you're having your radicular pain due to a disc bulge or herniation. I know Dr. Ben went over that before, where the jelly is kind of squeezed out of the disc, or the jelly squeezed out of the donut, the fluid squeezed out of the disc. It may cause pain or numbness or tingling or symptoms down your leg. So we do them over at the Pain Institute of Long Island. It is done under the X-ray machine. That's fluoroscopic guidance. It's a minimally invasive injection. You're in and out the same day in a couple of hours, which is with the check-in process and getting ready for the procedure and recovery. But the actual procedure can take 5-10 minutes to do. It's done with or without sedation. And it's basically a steroid that's used to inject the medication into the epidural space. And the goal, of course, is to help getting you pain relief, reducing your inflammation, and getting you back to functioning the way you want to do and get all the things, do all the things that you want to do and that you love to do. And it can be repeated. There are certain guidelines based upon your insurance and depending on how you do with the injection. So that would be reassessed afterwards in the office. Next slide, please. Facet blocks and injections, those are also done to treat axial back or neck pain, and that's pain that does not radiate down into your arms or legs. A lot of the times I get complaints from patients, and especially in their neck, oh, I have pain when I'm driving, when I'm looking over my shoulder, and it just remains in the neck, or they get the occipital type of headaches up the back of their head, or maybe they have back pain that's worse in the morning, or pain that you get when you lean backwards or twist. So that's all that axial back and neck pain that could be from the facet joints. It can radiate into your buttocks or shoulders, but typically, again, not past those regions down the arms or legs. So the first step, what we do is we take you over under fluoroscopic guidance, again, in and out, same day, with or without sedation, depending on your choice and your insurance. And we do a diagnostic medial branch block, and sometimes we can also do a facet steroid injection. So they would basically numb up the nerves that supply these facet joints that we think are causing your pain due to their arthritis. And we see you in the recovery room afterwards. And if you get relief that day, we know we're in the right spot because that anesthetic will kick in right away. If we do the facet joint injection with it, that's just a therapeutic touch where we can give you some steroid and hopefully you get a little bit longer lasting relief afterwards. So if this is successful, you would have to do it possibly a second time, depending on your insurance. And the third step would be to do the radiofrequency ablation where we actually burn the nerve away. And that is a semi-permanent solution. It can last between 6 months to 2 years on average. And it really just depends on how fast your personal nerves grow back, then the pain would come back. So when the pain comes back, you just have to repeat the ablation again if you had success initially. We have tons of patients who come back once a year, once every 2 years with the same type of pain. They just come back for their ablations and they do great. Again, it's minimally invasive. You're in and out under the X-ray machine and can provide relief for those 6 months to 2 year range. Next slide, please. And lastly, the Intercept procedure. This is something that's newer on the market. We've been doing this over the past 4 years since I've been involved in practice. It's really been a game changer for our personal practice. And I've loved seeing the results that the patients have had. Most of the time years before, we were really focusing more on the disc as being a source of pain and not the end plates. And now we know with this, the basivertebral nerve that's located inside the vertebral body that runs up and down. You can see there the green little tree branch that's running up and down in that bone there is really innervating the end plate of the disc and causing pain. Next slide. So over time, you can get a disc herniation, and after that, sometimes the inflammatory cascade can occur where all the contents from the disc will leak out around the disc and cause an inflammatory response, which now is a biomarker for the procedure, which can cause pain. So if any time you have pain when you're sitting for a long time, it can typically be midline, pain when you're bending over, flexing forward, going to pick up your grandchild, pick up a baby out of the crib, driving and sitting for a long time, or going from a sit to stand position. Those are really the key findings of what we're seeing with patients that may be a candidate for this procedure. There's not many things in medicine that have a biomarker for treatment, and you have to have those modic changes, which you can see with the yellow arrows there, which we call the hamburger sign in our practice, where you see that black disc that's generated. the white haze around it is the bun, and the black disc is the meat. That's all inflammation, which we think can cause pain. That's a motive change. Next slide, please. So again, the characteristics, we kind of related this to real life: bending over, gardening, picking up something, driving for a while. Patients that are commuters often say they have pain when they're sitting for a long time, bending over to tie your shoes, being unable to exercise. These are all things that could be potentially make you a candidate for this procedure. Next slide, please. So again, the procedure is minimally invasive. You're in and out the same day. It can be done under general or sedation, depending on your risk factors, your comorbidities, and what you discuss with your physician and anesthesiologist. There's nothing left behind, so it's implant free. You're essentially just burning that basivertebral nerve that you see there. And so far, the studies show that the nerve is not growing back. The studies are now out over 7 years, and these patients are still having long-term durable pain relief, and I'm seeing that personally in my own practice. Next slide, please. So again, straightforward. You're accessing the pedicle, step 1. Step 2, you create the channel with the cannula. 3, placing the probe, and then 4, ablating that basivertebral nerve. So the procedure can take about 45 minutes to an hour, hour and a half or so, depending on how many levels are treated. Next slide, please. And Intercept has amazing data. They have 2 level 1 randomized control trials that are far superior with their results. It's the SMART trial and the Intercept trial. The SMART trial is now actually out 7 years, and it's showing sustained pain relief. You can see here the percentage of improvement of reduction in patients' pain relief. There's a lot of patients that get between at least 50 to 70% relief, and even 75 to 100 with decreased opioid use and decreased injection use thereafter. And we all know back pain is multifactorial, so you may have a combination of this as well as other pain generators. So this definitely could make you a candidate if you have some of these signs and symptoms and those changes on your MRI. Next slide, please. So now I'm going to hand it over to Dr. Brown, who is going to be talking to you guys about the Vertiflex procedure and the Biodisk.
Thanks, Kristen. Hey, everyone. Thanks for joining. I'm Dr. Brown. I'm one of the founders of the Pain Institute of Long Island. I work with Kristen. So we're going to be talking about 2 different kinds of pain here. Patients who come in will frequently say they either have what we call axial low back pain, just meaning that just their back hurts. And then there's back and leg pain, signs of radicular pain. People call it sciatica, neurogenic claudication. So these are 2 newer treatments for both of these kind of pain. So next slide. So the first one we're going to talk about here is the Viadisk. This treats degenerative disc disease, age-related wear and tear of the discs that can cause loss of disc height, dehydration, discogenic pain. This is basically just an easy injection into the disc to help revitalize them. I describe this to patients as regenerative medicine for the disc. Okay, it's one of the earliest signs that we can see, this degeneration of the disc, which will show as we age, we get wear and tear of the disc. We start to get disc desiccation, which is a drying out of the disc, loss of disc height, and then we can start to get some discogenic pain. This is a simple injection into that disc again to revitalize that disc. Next slide. So some key features: it's designed to mimic native healthy nucleus pulsus. It contains approximately 80% water by weight in its native state. It maintains its water binding ability and can be reconstituted to its original state. These 2 pictures here basically just show your natural nucleus and then the injectable implant after it's reconstituted with saline. Next slide. So what we're treating here, again, is that axial low back pain as opposed to patients that have sciatica, radiculopathy. That's not what we're treating here. We're treating just people that have axial low back pain. So particularly worse with flexion. So similar to, as Kristen was describing, patients with the Intercept procedure, it is more this anterior spinal column pain, patients that have difficulty sitting for long periods of time, long car rides, patients who, more pain with flexion as opposed to extension, perhaps patients that have tried other diagnostic procedures, facet blocks, medial branch radiofrequency ablation. Maybe they only, didn't get quite the pain relief they were looking for. So this is what we're treating now. The slides down the bottom right are showing degenerative disc disease. The green ones are really showing kind of what we're trying to treat here. So the grade 1, grade 2s are healthy discs for the most part, maybe just the earliest signs of degenerative disc disease. The bottom right are too far gone. You can start to see actually, some of the changes like Kristen talked about, these motor changes there where the patient will probably be a better candidate for an intercept procedure to help their back pain. The middle where we have the green, there's the signs of degenerative disc disease that we're going to try and treat with this, where we're going to get this injection into that disc and help revitalize it and try and save it from becoming some of these worse off discs and increasing pain. Next. So how do we do this? It's incredibly easy. Like I said, it's just an injection. You come in, we'll do it in the OR. You'll just be laying on your belly. You'll be sedated. I numb things up for you. I get one needle into that disc, nice and easy, and inject, and it's over in 10 minutes. So it's not a terribly invasive procedure. It's very low risk and not painful at all to do the procedure. Next slide. So this is just kind of what patients should expect from this. It's not an immediate relief. So we don't inject it, the patient walks out feeling great right away. Again, it's regenerating that disc, so it does take some time in patients by the patient. In the initial phase, they may have some increased pain in the first few weeks, just kind of as initially it's just the pressure, and then as it's just kind of incorporating itself into that disc. We prescribe muscle relaxants, back brace, that'll help with any of that initial pain from the procedure. And then that'll slowly get back to baseline. And then over the next 4 to 12 weeks, the patient will notice their pain will decrease. Next slide. So conversely, we're going to talk about in this next procedure, patients that have the back and leg pain. So patients that have spinal stenosis. What is spinal stenosis? Most people have heard this term before. It's one of the most common conditions treated in pain management. It's an arthritic narrowing of the spinal canal. And what that is if you kind of look at the bottom right pictures there, you can see there's a very open spinal canal with plenty of space around the nerves. In the top right picture, in the bottom right, you can see it's a much more narrowed around the spine. And there's a couple different contributors to this. Typically, the big three are degenerative disc disease, ligamentum flavum hypertrophy, calcification, thickening, and then facet hypertrophy. So as the joints, so that's kind of all the triad is. All three of those can contribute to this narrowing of the spinal canal. And it's just a common occurrence with aging. As we get older, all those factors come into play and will narrow. It's most common, particularly at the 4-5 level, just because of the spine where it angles there. So patients that have this, what do they typically complain about? Again, not just back pain. So then what these patients will complain about is pain in their back sometimes, but also their legs, one leg, both legs, particularly with standing and walking, relieved with flexion. So these patients can sit all day long, unlike the degenerative disc patients I just spoke about, where they may have difficulty with long car rides. Patients with this problem can sit all day long. They're happy as a clam. When they stand and walk, that's a different story. They go out to get the mail. They try and walk down the block. Then they start to either get sciatica or heaviness, weakness in their legs relieved. They feel like they got to sit down, and then they can get up and go again for a little while. The most common thing is the shopping cart sign, where a patient will go to the supermarket and they feel relief with sitting over or leaning on the shopping cart as they get around. Next slide. So there's different kinds of central stenosis depending on where it is. There's central stenosis, so typically that can be degenerative disc disease, a disc herniation, ligamentum flavum, that ligament in the back getting thick and calcified, lateral recess stenosis, a little bit further out, and then foraminal stenosis, the furthest out. And they all kind of present a little bit differently, as you can see here, some of them. And that's really like up to us to kind of decide what seems to be the main pain generator for you. So the Vertiflex procedure that I'm discussing now will treat essentially all of these. So depending on which one is causing your pain, it has the potential to help all of them. Next. So the key advantages of the Vertiflex procedure, there's no resection of anatomical structures. So your anatomy is the same once I'm done. You're not changed in any way other than the small implant. It's delivered through a very small cannula. Basically, I make a small incision about very tiny, just over the area where the implant goes. I place a small working cannula through that incision and get the implant, and it's deployed at the level that we're working at. I have a little model here. You can basically see just how small that implant is. So the incision is just a little right over that. There's good data to back it up. We have 5-year data so far. Patients are still doing well at 5 years, and studies are still ongoing. I know I have patients that are doing fantastic, very close to that. Completely reversible. So trying this does not preclude you or make you not a surgical candidate anymore. If for some reason you didn't get the relief you were looking for, or something else occurred down the line that required surgery, it's completely reversible and can come out without any issues. The procedure, again, placement, it's placed inside, it's done in the OR. You're basically laying on your belly. I do this under sedation. You don't require general anesthesia, so there's no tube down your throat. You're breathing on your own. You don't have to undergo any of the dangers of general anesthesia and the risks that come with that. I can do these in as little as 10 minutes. So, you know, it's not a big surgery that's going to require any major downtime. You do not stay in the hospital for the procedure. You go home the same day, and I've had many patients who tell me they feel a difference as soon as they're walking to their car after their procedure. Next slide. So this is just showing some preoperative and postoperative imaging. As you can see on the left picture, there is some narrowing at some of the levels, particularly 3-4 level there. And then afterwards, you can see that the spinal canal is opened up once the implant is in place. Next. So who is a candidate for this? Basically, it failed conservative care. I mean, that's pretty much a given. You know, I always tell patients, most people are going to have these kind of problems in their life, this back pain, leg pain. 80% of them probably never need to see me, you know, or any of my colleagues. To just give it some time and it goes away. But, you know, once you've tried all the other more conservative things we talked about, it's still going on, you know, then it's time to consider it. Incomplete relief. So, you know, one of the most common things is epidural steroid injections for this. So it's typically not first line. People that have spinal stenosis, I'll do an epidural and they may be fine for a year, 6 months. It's when it's less. So sometimes there's patients that maybe have had an epidural and it lasts them a week, maybe less, you know. So they're the patients where I tell them, you know, epidural steroid injections are not magic. You're just injecting steroid into that space. At the end of the day, if the nerves are constantly being compressed in that space, no matter how much steroid I put in there, you're going to still have pain. So it can only be so effective. So at that point, you need some kind of decompression, whether traditional surgery to open that up or something like this implant, which can take the pressure off the nerves and allow, you know, an injection to possibly help. High surgical risk patients. So I've done this for patients who are in their mid-90s, who were absolutely not candidates for traditional surgery, and otherwise they were just left to sit on opioids and really not enjoy the last years of their life. I had a patient who was 92, was able to successfully perform this, and he was up enjoying life, taking walks with his wife again, and couldn't be happier. So if you've been told you're not a candidate for surgery, that may be true for a larger surgery, but for something like this, you may be an excellent candidate for. It can be performed. I've done this for patients adjacent to another fusion. So if you had a traditional spine surgery, what happens is you get adjacent level disease, and sometimes the level above can start to break down, narrow in. And if you want to perhaps try something different from avoiding just extending that fusion, you may be a candidate that I can place this, and I've had that work very well for some patients too. Next. So basically just looking at some of the data here, 66% improved back pain scores from baseline 5 years, 75% improved in leg pain, 85% decrease in the proportion of patients using opioids. So that's always great, especially in this age class, you know, lowering the opioid dose, and 90% patient satisfaction at 5 years, which is very impressive. Next. All right. Well, thanks, everyone.
Thank you very much, Dr. Brown. Dr. Brown, for the audience, Dr. Brown and all our speakers will stay on at the end. There's a Q&A section on the bottom. You can start actually filling in some of those questions. If you have some, we'll address those at the end. I'd like to introduce Dr. Dan Burke. Dr. Burke is a neurosurgeon that operates at Mather Hospital, and he's part of the NSPC neurosurgical group. And he's going to talk to you about concepts of spine surgery, when they're indicated, and what kind of procedures he uses that are minimally invasive, and some of the latest things that he does. Dr. Burke.
Thank you, David. Good afternoon, everybody. Again, my name is Dan Burke. As David said, I'm a neurosurgeon here in Port Jefferson. I specialize in spine surgery and specifically minimally invasive spine surgery. I'm going to be brief and try to explain what spine surgery is and what I do, and when spine surgery makes sense, and try to make it understandable without using excessive technical jargon and medical terminology. So next slide. So just in terms of the spine, a comedian, what is spine? How do you understand it? One of the reasons I enjoy being a neurosurgeon and being a spine surgeon specifically is that to me, it's very simple. Comedian once said, spine is a stack of bones with your head on one end and your butt on the other end. They use different terms, but that is essentially true. More relevant is that it's a stack of bones that makes a tube. And it's a tube that contains important structures, your spinal cord and your nerves. And these structures, when they're under pressure, as has been explained, causes various symptoms and neurological problems that can run the gamut from simple pain all the way to paralysis. The spine is not only a tube, but it has a series of openings on either side called foramina. And those are the openings through which the nerve roots travel outside of the spine to the rest of your body. So as a spine surgeon, I often explain that there's only two things I really do. I'm either taking things out, I'm either removing tissues, or I'm putting things in. This is basically describes every single surgery I've ever performed. Removing things means taking out tissues or abnormal structures like a tumor or a blood clot or a hemorrhage. It can be a disc herniation, an arthritic part of your anatomy like the facet joints and so forth that are causing pressure on the spinal cord or nerves. Or I'm putting things in, and those things are either artificial or organic, either bone graft or spinal implants, as has been discussed and depicted, to put your spine back together. And often these two things go hand in hand. Sometimes the structures that need to be removed require it to be reconstructed with hardware and fusion. So indications for surgery. When is surgery necessary? Reality is that in the vast majority of cases, surgery is not necessary on the spine. And between David, Dr. Brown, Christine, Caitlin, and all the other providers at the Mather Back and Neck Pain Center, in the majority of cases, you will not end up seeing someone like myself, and your symptoms will be improved and the problem solved without surgery. But there are cases where surgery is indicated, where surgery is necessary, but often it's elective. So there are certain surgeries that are optional and are a last resort after all other treatments have been exhausted. And there are surgeries for the spine that skip over all of those non-surgical treatments because it really is necessary. And without surgery, patients will likely experience neurological deficits or unrecoverable issues. So indications for surgery when they're necessary, again, when things are either pushing on nerves or spinal cord and other treatments won't help or have not helped, or if there's instability. and your spine is unstable or deformed or out of place. Reasons why you may have pressure or pushing on your spinal cord are, as has been discussed, the herniated discs, various issues causing the narrowing or stenosis, the pressure and compression on your spinal cord. And it's important for patients to understand that spinal cord does not extend throughout your whole spine. You have spinal cord in your neck and in your thoracic area, your chest, and the spinal cord ends at the very bottom of the thoracic and the top of the lumbar spine, what we call the 12th thoracic vertebra and the first lumbar vertebra. Below that is just nerves. If you have narrowing or stenosis in the lumbar spine below the spinal cord, it's not as serious as an issue as when you have it in your neck, and that can cause a condition called myelopathy. Here you see under spinal cord compression, and this does require surgery because it amounts to a slow motion spinal cord injury. And once your spinal cord is injured, like Christopher Reeves falling off the horse, we don't have the capability to go inside your spinal cord and repair the damage. Other issues, as I mentioned, instability and deformity that aren't really going to get better with the other varied treatments that are available. Next slide. So again, this is going to be repetitive, but the conditions that you see here, the arthritis, the drying out and degeneration of the discs, the herniations and the pinched nerves in the lumbar spine, a surgery is not mandatory unless you have a weakness or a numbness, what we call a deficit neurologically. If your foot is dropped from the disc herniation pushing on the nerves and you can't pick your foot up, this requires surgery. And if you wait, then this could become a permanent type of paralysis or weakness. But many of these disc herniations, as impressive and large as they appear on the MRIs, will get better on their own. And with the help of the pain management and physiatrists and physical therapists who are available through the center. If everything else fails and you're still suffering pain, or if you have a neurological compromise, then you will be referred to someone like myself. Next slide. So now we're looking at the cervical spine or your neck. And here you can see the long gray stripe is the spinal cord. And this is a different situation than the lumbar spine where you only have nerves. The arrow, the red arrow here is pointing to a white splotch in the spinal cord. And that's a sign of the myelopathy or the spinal cord disease that would require surgery to stop the insult on the spinal cord and prevent you from getting worse. If left untreated, this condition, which all three of these MRI images show in different patients, if left untreated, you will suffer what we call stepwise deterioration over time. You'll have a new numbness or weakness, then it'll be stable for a while, then the numbness and weakness will get worse. And as it progresses, each new symptom becomes unrecoverable, even with surgery. So if you have spinal cord compression and signs of spinal cord disease like this, then we do recommend surgery early. And it can be confusing because when the spinal cord is being injured like this, it does not necessarily cause pain because the spinal cord itself doesn't have sensory nerve fibers. So the symptoms can be very subtle and insidious. But in these cases, surgery is important to have early in the disease process. Next slide. So what are common surgeries? As I had distilled all of spine surgery down to removing things and implanting things or taking things out and putting things in, that's what the surgeries amount to essentially. So anything that sounds like ectomy, discectomy, facetectomy, laminectomy, or otomy, laminotomy, all of these are the removing the offending structures, pathologies, or anatomical structures that are causing the narrowing, that are causing the pressure on your spinal cord and nerves. If the discectomy involves removing entire disc, as it does for the cervical spine in most cases, something has to go in that space, and that's the putting things in. And the options for your neck are either a fusion or an artificial disc, and there are advantages and disadvantages either way. The anterior cervical discectomy and infusion is one of the most well understood standard reliable surgeries that we do with very, very good outcomes. If your disc herniation is way off to the side, for the neck, there are cases where we can just remove or do the ectomy, the discectomy for the offending fragment without having to take the remainder of the disc out. But you need careful evaluation by neurosurgeon to make that determination. The artificial discs, there's misnomer amongst patients that if you have fusion, your neck will be stiff and you won't be able to look around, which is not true. That is not the advantage of the artificial disc. It's a biomechanical advantage to prevent the adjacent disc disease that Dr. Brown mentioned for the disc above and below. But in reality, having a fusion 1, 2, or 3 levels is not going to prevent you from turning your head side to side and looking up and down. Next slide. This is a depiction of the artificial disc, which is a newer treatment. It's actually only FDA approved for 1 or 2 levels. So if the disease and the pressure on your spinal cord extends for more than 1 or 2 levels, or if you have bad arthritis, it's not a good option for you. It's more of a restoration procedure. So if you have extensive deformity or degeneration, or if your neck is not moving right to begin with, the artificial disc is not a good option. In that case, you most likely would be discussing a fusion with your neurosurgeon. So when to operate, the answer is either after all other options have failed and no further non-surgical conservative treatment remains, or if your spinal cord is showing disease, if you have instability, deformity, or if the symptoms are so severe that it doesn't make sense. If your pain is of a severity and you've tried some conservative treatments, but you're really, really suffering and need relief sooner rather than later, is another reason why you might consider surgery. Next slide. Common lumbar surgeries are similar to the cervical surgeries. They differ in technique and approaches. How we will access your spine varies in the neck and in the thoracic and lumbar spine because of the surrounding anatomy. In your neck, you have other important structures, your breathing tube, your eating tube, the large vessels that carry blood to your brain, and so forth. But the surgeries in concept are the same. Again, we're either we're doing discectomy or laminectomy, which means unroofing. All of these are to relieve pressure and free up spinal cord and nerves, or we're doing rebuilding either fusion or artificial disc. Artificial disc in lumbar spine is very rarely performed in the United States, as the data is not very good for the outcomes. And it does require a vascular surgeon to move all your abdominal organs aside. So it's not as, doesn't make as much sense as for the cervical spine. Again, your spine is a stack of bones, so there's gravity, and the lumbar spine is the foundation, subjected to the most amount of weight from the rest of your spine on top of it, and therefore it requires more robust rebuilding, and that generally means fusion when we need to stabilize your spine in the lumbar area. Next slide, please. These pictures show the MRI on the top, shows, you can see without even being a doctor radiologist, that the spine has slipped off of itself, that the 4th lumbar vertebra has slipped forward on the 5th lumbar vertebra, and there really isn't any injection or therapy or treatment aside from surgery that's going to repair this. This needs to be physically brought back into place and fused in that manner. Another common point of confusion for patients is about the fusion itself. The X-ray here shows screws. You can see screws connected by rods. And this is necessary for the fusion, but is not the fusion itself. Fusion means bones growing together. Similar to if you break your leg, you fracture your tibia, you go to the emergency room, orthopedic surgeon puts it back into place and puts a cast on you. The cast is because if the bones have any motion, if they're moving at all, even on a micro scale, they won't heal or fuse or meld back together. And same is true with spinal fusions. Previously, years ago, before the screw and implant technology, you would have to wear a body cast and have extensive bed rest to allow the bones to fuse. Now we put the cast on the inside, and that is the fixation, the titanium implants, the screws and rods that hold everything together. The fusion happens silently over time. It can take anywhere from 6 months to 18 months after surgery. It's not something that the patients feel as part of their recovery, but it's something we keep checking on with x-rays until we're satisfied that the bones have healed together. So again, instability is an indication why you would need surgery as opposed to trying other non-surgical treatments. If your spine is not stable, if it's moving in abnormal ways that are threatening your neurological condition, your spinal cord, your nerves are causing severe pain, then it needs to be stabilized surgically. Next slide, please. So what is minimally invasive spine surgery? This is something also that there's a lot of misunderstanding and confusion about. In fact, in my experience, something like 80% of spine surgeons say that they do minimally invasive spine surgery, maybe 20 or 25% actually do. So how do you know, is the surgery really minimally invasive? Well, to make it simple, if it's not done through a tube of some kind, then it's not minimally invasive spine surgery. Minimally invasive does not necessarily mean small incision, although often that is the case, but that is not what makes it minimally invasive. Minimally invasive spine surgery really should be called minimally destructive. What it means is that the muscles and soft tissues that are between your skin and the problem in your spine are preserved and are protected and not cut and burned and dissected during surgery. And that is accomplished by spreading the muscles apart with tubes and then looking through the tube with some type of scope, a microscope or an endoscope to perform the surgery. And after the tube is removed, the muscles come back together. This results in less bleeding, less post-operative pain, faster recovery, less pain medication, and quicker return to work. But again, it requires special skills and equipment that not everybody is trained in, and not every hospital has the necessary equipment. In fact, Mather Hospital is one of the only hospitals in Suffolk County that I know of that has a full suite and array of minimally invasive spine surgery technology. Other local hospitals do not. So again, if your surgeon says they recommend minimally invasive spine surgery, ask them what kind of tube they're going to do the surgery through. If they say it's not with a tube, then remember the talk and that it may not actually be technically minimally invasive. Next slide, please. So that concludes a few words about the stack of bones and what I do to take things out and put things in as a neurosurgeon. I hope that was helpful to everybody.
All right, thanks, Dr. Burke. Hi, everyone. I'm Caitlin Conville. I am one of the nurse practitioners at the Back and Neck Pain Center, and I'm just going to talk to you a little bit about our program. Next slide. All right, so how is the Back and Neck Pain Center different? So you've heard a lot from all of our providers today, so I'm just going to give you a brief overview of some of the highlights of our program. So here at the Back and Neck Pain Center, we provide evidence-based multidisciplinary care, which is customized by a clinical team, a collaborating physician, and guided by a nurse practitioner. So again, when we talk about multidisciplinary care, I'm referring to the fact that we have multiple providers from many different disciplines, as you've seen today, spine surgeons, interventional pain management providers, physical therapists, and chiropractors, and we all work together to to coordinate your care. We even meet once weekly. We review patient charts to allow for providers from different backgrounds to weigh in on the selected treatment plan and provide their unique perspectives. At the Back and Neck Pain Center, we aim to treat your pain, the pain that you're currently experiencing, but we also aim to reduce recurrent episodes of back and neck pain, and we do that by teaching you about how to adopt a healthy lifestyle. We also avoid the use of high-risk pain medications. So while one of our goals is to alleviate your pain, we try to find the underlying cause of your pain and provide treatment that addresses that underlying cause. We also identify and address disparity of care factors. So I know Dr. Ben mentioned population health. So this is what he was referring to. So there are many factors that make it difficult for individuals to access treatment. And that includes things like financial obstacles, transportation issues, mobility issues, comorbid medical conditions, mental health issues, and just difficulty managing multiple appointments with different providers. So here at the Back and Neck Pain Center, we aim to identify these factors and provide assistance to make sure that you're able to get the treatment that you need. Next slide. All right, so our GPS system. So this is just an overview of what will happen if you do make an appointment at the Back and Neck Pain Center. So at your visit, one of the nurse practitioners will review any prior records that you have. We always ask you to bring those along if you do have previous imaging or any surgical history, to bring records of that. We take a very thorough history, and we conduct a physical examination that's focused on your back and or neck and just the specific pain that you're experiencing. So once we do that, we will present any findings to our multidisciplinary clinical care team of specialists to discuss each case, and then we find the best treatment plan for you. We help to coordinate first appointments with the appropriate provider, whether that be a physical therapist or a spine surgeon in a case where you present with a red flag. We also schedule follow-up appointments to monitor your progress throughout the course of treatment, and we periodically call patients via phone to check in as needed. Part of your treatment is obtaining any clinical tests that we need to do, any diagnostic imaging, and provide any medication that would be appropriate for your care. Next slide. All right, so at the Back and Neck Pain Center, we have support programs that provide additional care to patients as needed. So two such programs are the Mind Body program and Healthy Diet, Healthy Spine. So recent studies published in the Journal of American Medical Association found that Mind Body programs were effective for reducing pain and improving function in people with chronic low back pain. So, sorry, I just lost my slide too now. All right, so at the Back and Neck Pain Center, either myself or another NP can teach patients how to do deep breathing and simple yoga chair exercises. And this is referred to as mindful-based stress reduction, which helps to reduce chronic neck and back pain, as well as stress and anxiety. Healthy Diet, Healthy Spine is a program that involves an optional consultation with a registered dietitian, during which time you will discuss the importance of managing weight and how it relates to back pain, and focus on anti-inflammatory foods that you can integrate into your diet to help reduce inflammation in your body and thereby reduce pain levels. Here we have an example of the Mediterranean diet, which is an anti-inflammatory diet that we recommend for patients with back or neck pain conditions. All right, next slide. All right, if he's back on, I'm going to pass you over to Dr. Ben, and he's just going to discuss some more about our program.
Thank you, Caitlin. So we're going to wrap up here. So this is just some data from our center, which we've been working at Mather Hospital now for about 8 years. So we commonly get patient surveys, and 98% of our patients have had great outcomes. 96% were satisfied with the care that we render. And I think one of the reasons why you're seeing these kinds of data is because we take a very integrative team approach. As Caitlin said, we have clinical conferences where we meet weekly, and it's multiple providers looking at your particular unique personalized case, which we then generalize together and create a personalized care plan. You'd have to hop from doctor to doctor and specialist to specialist to get the very same thing. And one of the other things is you could see you had a wide array of specialists speaking today. They're pretty much at our fingertips. So if you need to see Dr. Burke, if you need to see Dr. Brown immediately, we get on the phone with them, and you're not waiting weeks and weeks in chronic pain and severe pain to see those people. So that's what makes our program extremely unique and extremely successful, is its integrative team collaborative approach, and collaboration means working together as a team to help you get better. And then the other thing that Caitlin mentioned too that makes us unique is that we look and search for the things that allow back pain to become recurrent, meaning Studies have shown that back pain recurs usually with a 50% recurrence rate in the first year and sometimes as high as 80% in 2 years. And that goes to what we talked about before, not identifying risk factors, not identifying the things that perpetuate back pain. Once you identify those things, we look to change those things and help you change those things, because that's what's going to help back pain from not happening over and over again and affecting your ability to live a happy, functional life. Next slide. So I'll go back to the last slide, if you would, please. So this will conclude our webinar. If you jot down that phone number there, we take almost every insurance plan. You would always start with seeing Caitlin or Kristen. You met both of them today. They're our coordinating nurse practitioners, and they take a very detailed history. They get the previous imaging, any previous consults that you've had. We order imaging if that's necessary. And then once a week, we would look at your case and then decide the best treatment that we collectively as a team, and this is multidisciplinary, think that's best for you to start with. So that's our phone number, 686-2565. Next slide. And if you prefer, you can email us. And our email address is up there, math.bmpc@northwell.edu. It's an extremely successful program because we get great outcomes and great results. I appreciate everybody taking the time out of their day to attend our webinar today. I hope it was extremely informative. I greatly appreciate all our providers and team members for speaking today, and I hope you all have a great rest of the day. Thank you very much.
Thank you to the entire Back and Neck Pain Center team for your extremely informative presentation. If anyone has any questions, you may enter them in the Q&A feature on the bottom of your screen. All questions are anonymous to protect your privacy.
So we'll wait a few more seconds to see if anybody has any questions. You can type those in and we'll answer them based on the specialty it was directed towards. Okay, looks like there are no questions. So thank you for attending and everyone have a great day.
Once you exit the webinar, you'll see a link to complete a brief survey. If you could please complete the survey, your feedback is extremely important to us and helps us plan our future programs. Thank you all for joining today's webinar. If you'd like to view other HealthyU webinars we've presented, you can find them at matherhospital.org/HealthyU.